Hello, RDs and RDs to be. Welcome to the RD Exam Ready podcast. I'm Zach Caseberg, your tutor, coach, and guide along the path to passing the RD exam. And my biggest passion is to help RDs and RDs to be just like you to know how to effectively pass the CDR exam. If that sounds like you, then hey, you are in the right place. I wanted to give a special shout out to the students that have gotten to join us for our recent YouTube Live. Last week, we listened and reviewed over some major food service calculations. We did selling price, EPAP, as well as break even point, and I appreciate everyone who was nice and patient with me as we kind of worked through some tech issues. As we do more YouTube Lives, this is going to get better and better each time. So I'm looking forward to that as much as you probably are too. One thing I like doing it on YouTube because it seems like it's really easily accessible to most of the students. And really, I want to give it just kind of an easy way for people to access the podcast and access the YouTube Live. So it's really cool to do that. Now, we're going to do another one of these coming up here in a few weeks if you are listening live. So I'm hoping to do another YouTube Live on February 4th at 7 o'clock Central Time. That'll be 5 o'clock Pacific, 6 o'clock Mountain Time, 7 o'clock Central, and 8 o'clock Eastern. During this session, we're going to be reviewing parenteral and enteral nutrition calculations. So if you're someone who struggles with PN or you struggle with EN, this is going to be a great lesson for you to join because I'm going to give you some effective ways to prepare for exam day. If you go and subscribe to the RD Exam Ready YouTube channel, go to the live section, you can click on it for notify me when any live goes up. Keep a lookout on the RD Exam Ready Instagram page as well for more practice questions and live announcements and more dates. And of course, if you haven't subscribed to the show that you're actively listening to, please do that just so you know when more episodes are going to come up. Now, the path to passing this exam really has to do with the knowledge that you intake and how you critically apply it. I'm such a broken record, and maybe I need a new broken analogy at some point, but I've always told you that all the knowledge that you pick up in digestion and absorption or human anatomy and physiology is directly tied to what you do and use in medical nutrition therapy. And that's because so many of the questions that are centered around MNT really have to do with what you know about the body, its function, where things are absorbed, and how things are going to be impacted when something goes wrong. I can't think of a better example of this than bariatric surgery. We're all well aware of the purpose of bariatric surgery. It's a very effective tool for treating obesity in patients. And even with the rise of use of GLP-1s, bariatric surgery is still proven to be an effective method for treating morbid obesity in a patient. Bariatric surgery, it's not necessarily just the physical manipulation of the body, it also centers around having a multidisciplinary team that can work on the patient's other comorbidities, as well as having the team to help treat some behavioral and emotional factors that are tied to eating and tied to obesity, morbidity, and mortality. Today, I'd like to review over some of the basic bariatric surgeries that are out there, give you some background on them, and then connect some of the MNT guidelines. I want to preface this that it's very important that you've listened to other podcasts, including the digestive enzymes, digestive hormones, to get a good understanding of how the body and specifically the GI tract is going to be manipulated and changed. Particularly, I want you to take the mindset of understanding that the surgery that the patient goes through is going to impact things such as where things are absorbed, how they're absorbed, and the types of minerals and vitamins or physiological functions that change after a surgery is completed. So let's dive in to our different MNT guidelines in our surgeries today. Firstly, I think it's good to know specifically what type of patients may need bariatric surgery. Obviously, having a high BMI is a requirement, but let's make sure we know the specifics here. A bariatric surgery is recommended for patients with class 3 obesity with a BMI of 40 or greater, or if you have a BMI of 35 or greater with comorbidities such as diabetes or heart disease, that would be recommended to undergo a bariatric surgery. A patient would be a good applicant for bariatric surgery if they've previously tried a comprehensive program to lose weight, and that would include things like exercise, lifestyle modification, psychological counseling, and just shown that they were not able to reduce their body weight by these means. There's about two different classes of surgeries, and some of them are meant to be surgeries that are restrictive, and some are ones that are meant to be malabsorptive. And what we mean by that is restrictive would mean like reducing the amount of food intake you take in, and malabsorptive would be trying to reduce the amount of macro and micronutrients that are absorbed and can enter the GI tract. So let's kind of start as we go through by reducing the amount of food that can be eaten at one time. And the surgeries that would fit with this would be a gastric bypass surgery, gastroplasty, and gastric banding procedures. The very first one we're going to start with is called the vertical sleeve gastrectomy. Before we dive in, let's understand our terminology here. Gastrectomy would be gastric or gas or the stomach, and ectomy would be removal of, right? Knowing that is going to be very key here. A vertical gastrectomy is a restricted procedure that is limiting the amount of food that enters the stomach. Up to 85% of the stomach is surgically removed, leaving kind of this narrow banana shaped portion of the stomach between the esophagus and the duodenum. Because the pyloric sphincter is kept intact, which that's the sphincter between the stomach and the duodenum, you're still going to absorb nutrients through this area when you maintain that pyloric sphincter function. The section that is removed from the stomach is primarily that large chunk that is removed, and that is the area where the hormone ghrelin is secreted. And remember, ghrelin is your hunger hormone, right? That's going to be high in periods where I'm very hungry and low when I'm very full. During obesity, we always end up with some level of dysregulation of ghrelin where the ghrelin hormones may not be signaling the things that they should be. So, a sleeve gastrectomy is going to be a removal of a large section of the stomach to leave a much smaller pouch to feed into. Our next surgery is restrictive. It's called a laparoscopic adjustable gastric banding, also known as gastric banding, to save me saying that every time. A ring or band that is silicone in nature is placed into the abdominal cavity and it's attached to the upper part of the stomach. Imagine like you squeeze the top of a balloon and you're kind of forming that balloon there. So at the top is going to be this small pouch, very small, where contents are going to go into. Then you're going to have the bottom of the stomach as well. The small pouch has a narrow opening at the bottom, and that's where the food is going to pass through that narrow opening into the rest of the stomach. This band has the ability to be inflated or deflated as it needs to be once the surgery or the procedure is completed. So what we're doing is we're forming that small pouch, and that pouch really serves as your new stomach. Because it's so small, it's going to delay the emptying of that pouch, and going to give the patient a sensation of fullness much earlier than they were used to prior to the procedure. From a technical sense, it's the least invasive of the surgeries because we're not really removing a section of the stomach, we're not redirecting things, we're more just inflating or deflating this silicone ring to give them the sensation of fullness here. Our third one that we talk about today is going to be the most common procedure in the United States, and it's called the Roux-en-Y gastric bypass. Now, this one is going to be restrictive and malabsorptive. To imagine this surgery, I want you to picture a normal stomach, normal GI tract. We're going to start by making a cut right into the stomach, kind of a C shaped cut. And at the top of this forms your new gastric pouch. That gastric pouch is where those food contents are going to be dumped into. That's your new little stomach that we have here. And attached to that little gastric pouch, we add this gastric limb. It's just a long tube that goes from that small stomach pouch and it connects to the small intestine. The remainder part of the stomach that we haven't talked about, it's still intact. We keep this portion of the stomach, it has not been removed, but we make sure that it too has a channel to be connected to the small intestine. In a way, this is a very important thing to understand right here. The duodenum is being bypassed in this type of procedure. And by bypass, we're kind of saying it's being skipped here, right? The remainder of the stomach that we talked about is still attached to the duodenum, but that small, tiny stomach pouch, that is not being connected to the duodenum. It's being connected to your jejunum, right? And this is so key to the malabsorptive piece. By bypassing that large section of the stomach and the duodenum, and really the first part of the jejunum, we are losing much of our ability to absorb nutrients that would normally be absorbed in those areas. But by leaving that large stomach area, that extra, I'll call it here, and that part of the duodenum, we are actually going to still get secretions from the stomach, from the liver, from the gallbladder, and the pancreas, because a lot of those are closely connected to the duodenum, and we still want those secretions. So those secretions will still take place. They're just going to enter into the jejunum and mix with those food contents. So it's kind of like we aren't absorbing as many nutrients as we normally would, but we're still getting some of those same secretions as we would in a normal GI tract. I highly recommend checking out the pictures of Aru and why. It can be a little complicated, but if it helps put the picture together, I would say do it. Finally, our fourth final procedure we're going to talk about here that's used for weight loss is called a duodenal switch with biliopancreatic diversion. Let's start once again with a normal GI tract to picture it. Firstly, we're going to perform a gastrectomy. We're going to remove a large portion of the stomach, only leaving this banana shaped portion like we talked about in the beginning. An incision is then made in the duodenum, okay? And at that stage, that remaining portion of the stomach is then connected to the ileum, okay? So let's run that right back. You have that banana portion of the stomach. Normally it would be connected to the duodenum, but we're going to cut the duodenum in half, and instead of having that duodenum connected to the stomach, we're just going to connect that stomach with a tube to the ileum. So now the food contents are going into the stomach, the smaller stomach area, and then into the ileum. Understand that? So it's like we're skipping the duodenum here. Okay. Now, that remaining portion of the small intestine, which is going to include the duodenum and the jejunum, it's still left intact, folks. By leaving these intact, we are once again getting those secretions from the liver, the gallbladder, and the pancreas. We're just rerouting them to enter the small intestine much later in the ileum than what they're typically used to. Sometimes I get a little confused with the difference between a Roux Y and a duodenal switch, so maybe let's talk about the differences to help us out. In a ruin Y, we're still leaving that remaining portion of the stomach intact. We are not removing it. So you still get some gastric secretions. But in a duodenal switch, we're doing a gastrectomy. So that portion of the stomach is actually being removed. Secondly, the difference between them is the Roux Y, we're connecting that small stomach pouch to the jejunum, whereas in a duodenal switch, we're taking that banana shaped stomach and we're connecting it to the ileum there. In both cases, it appears we're going to leave the duodenum and the jejunum intact to allow for those secretions from all of those accessory organs. But probably the largest difference between the two is the duodenal switch, we're not getting as much absorption in the jejunum that we would have gotten in a traditional gastric bypass. Now, let's go into the MNT a little bit. Much of the MNT is going to be the same for a few of these, but there's just some slight differences. Firstly, directly after surgery, I want to talk about how we're going to progress a diet for really most of these surgeries. A patient is typically going to be put on a liquid diet first. Whether it's clear or just full liquids, I don't think it matters too much to me. It would probably matter for the physician there. But really, they won't take more than 4 ounces of total liquid at a time, and we'd want to focus on foods like water, broth, unsweetened juices, diet drinks, or cream soups that don't have any chunks or thickness to it. Then we would gradually increase to a semi solid and puree diet, with the volume would increase just a little bit here to what they could handle, and we'd keep that patient on that diet from about 3 days to 3 weeks or so. This could be any type of blenderized pureed foods here. So, soft pureed meats, fish, eggs, chicken, turkey. pureed fruits and vegetables that are cooked until very, very soft without skins, hot cereals cooked in milk and yogurts. That would be all things we could include on that pureed diet. Once we're in weeks 3 to 6 after surgery, we're going to progress to being going to more of like a softened diet a little bit. Our volume is still going to stay pretty low, probably not one more than 1 cup total per meal. And we would be doing those soft foods here. So mashed potatoes, diced meats, canned or soft fresh fruit, cooked vegetables, again, very softly cooked vegetables without any fiber. We would want to avoid any fried or crunchy items or breads at this phase, keeping everything very softly cooked. Then, from 6 weeks and beyond, depending on the patient and depending on the surgery, we could then progress to regular small meals and snacks. No more than 1 cup total. We're using a very small volume, but we should be able to handle most regular foods with the exception of a few. Things like popcorn, nuts, dried fruits, stringy or coarse fruits and vegetables, bread, granola, trail mix. Are all foods we want to avoid with these because they can get caught in several areas. And also, it's just probably not going to do well for a healing GI tract. Now, I want to talk about the specifics of the MNT between these. I've gotten a couple different notes from different texts here that we'll talk about as we go through it. But let's start with this sleeve gastrectomy here. For sleeve gastrectomy, it's recommended to start supplementation a few days post op, and for most of these conditions, we would probably start supplementing shortly after. For a sleeve gastrectomy, we would want them to focus on high protein liquids and eventually foods once they progress to that point. We need them to be on a high protein diet at this phase because think of it, you have such a small portion of your stomach a lot of the time that we want to avoid. The fact is, they just can't get a lot of food at one time. So, if we want to focus on something, we need to focus on high protein because if they don't, they're going to lose muscle mass over time just through malnutrition. So, keeping high protein rich liquids, supplements, protein powders mixed with water, lactose free milk, these are all things that we could manage for them to eat. And we'd want this patient to maintain a low sugar liquids or to avoid any high sugar liquids during this time, because those high sugar items may cause a condition called dumping syndrome, which we're going to talk about here in just a few minutes. The patient would also begin their multivitamin with minerals, and in particular, some of the vitamins and minerals that we would focus on would be these. For vitamins, we would want this patient to focus on vitamin D as well as vitamin B12. The vitamin D is going to serve to help to maintain their bone mineral density post op. And I would ask you, why do you think they need vitamin B12, folks? Well, the stomach itself is being impacted in a sleeve gastrectomy. Intrinsic factor is also more than likely going to be impacted too. So we want this patient on a B12 supplement because they're going to have malabsorption of vitamin B12 and less involvement with the stomach. It's similar to our need for vitamin D. We're also going to want the patient to consume a calcium supplement. Specifically, calcium citrate is commonly recommended because calcium loves acidic environments. It helps with its absorption. And because your stomach is so impacted by this procedure, it's going to help to give it a little bit of that citrate to make the calcium more easily absorbed. Especially when my stomach has been partially removed, I'm not going to have as much gastric acid contents there. And one note that I just thought of that I want to mention here too. When I mention B12 supplements in all of these conditions, in particular, it says to do a sublingual, oral, nasal, or an IV B12. What they're basically saying is they would maybe recommend not doing a B12 pill or a B12 supplement in that form because for a lot of these conditions, you're not going to absorb B12 very effectively. And so it would be recommended to give it maybe in the sublingual form where they can absorb it through the cheek or give it through an IV, for instance. So just wanted to make sure I reiterated that there. For a gastric banding procedure, the MNT needs are a little less intense as these other procedures. So, as noted in the text, a patient with gastric banding would not require as much supplementation of folic acid, iron, or B12. I have one text that says we may need it, and then the Krauss manual said specifically they do not require supplementation of those things. And to me, I think that makes sense. This is not a malabsorptive type of procedure, it's one that's restricting. So you should be able to get vitamins and minerals. It's just more of a question of are you going to get enough of them to fight off deficiencies? Once a patient with a gastric banding procedure is kind of through that post op diet progression period, they're largely going to be focusing on the volume of the meals that they consume. Once they've recovered, their meals are going to be very small, and they need to make sure that they chew slowly and chew very well before they swallow. Because a lot of the times foods can get lodged or a little bit stuck in that area, and sometimes this leads to some nausea and vomiting. In addition to small, frequent meals, I found the care manual also mention that the patient should be recommended to still get a calcium citrate supplement in addition to vitamin D to help maintain bone mineral density. Also, of course, focusing on high protein foods to help prevent any muscle loss. Now we're going to go on to a gastric bypass. For a gastric bypass, the patient is recommended to focus on high protein foods to maintain their muscle mass. To avoid my to avoid vitamin and mineral deficiencies, the patient would have to consume the following vitamins: vitamin D, vitamin B12, folic acid, and vitamin C. For minerals, the patient is recommended to consume calcium citrate and elemental iron. Remember that we are not properly absorbing these vitamins and minerals, especially minerals, because the duodenum is largely being skipped, and minerals typically are absorbed in the duodenum, but also in other areas too. We're still getting some use of those gastric secretions or some of those accessory organs too. So we must make sure that the patient is consuming things like folic acid and like iron, because under normal circumstances, they would absorb these things just fine. But in this case, we are not. Of course, meals from here on out after recovery would have to be small meals and snacks, focusing on high protein foods. The patient is recommended to meet their fluid needs and get adequate amounts of fluid while trying not to drink fluids too fast, which would cause this sensation of fullness or pressure in that small stomach pouch. A patient with Roux-en-Y gastric bypass also must avoid foods that would cause dumping syndrome. So, again, we're going to avoid foods with lots of added sugars. And again, we'll get to the dumping syndrome here in just a moment. Finally, for a duodenal switch, we're going to share much of the same nutrition requirements as the Roux-en-Y. Patients with a duodenal switch will be recommended to consume calcium citrate in supplement form. In addition to zinc, copper, and iron will be minerals that they need to focus on. For vitamins, they should make sure that they get thiamine, vitamin B12, folate, vitamin A, and vitamin K, as well as vitamin D, because they're having a lot less use of their jejunum and requires supplementation of these things. Of course, we're going to focus on small, frequent meals for this patient, avoiding large volumes of liquids, and keeping everything high protein. I wanted to take some separate time to discuss dumping syndrome with you and make sure that you kind of know it. It could get its own podcast completely, but I like to describe dumping syndrome in several steps. The definition of dumping syndrome is a rapid amount of stomach contents entering the small intestine, causing a high osmolar load. This high osmolar load leads to a draw in of fluid into the small intestine. Remember, in osmosis, where water is going to flow from an area of low solute concentration to the high solute concentration. That's what's occurring in dumping syndrome is if a patient consumes a very sugary liquid or sugary substance, that sugar dumps right into the small intestine, being the high solute load. Then the water falls and flows into the small intestine and it draws towards that solute that's in the small intestine. In early stages of dumping syndrome, a patient will get diarrhea, nausea, tachycardia, excessive sweating, and a headache. And in these early stages, they end up with hyperglycemia or a big spike in their blood sugars because they just taken in this very sugary substance. And of course, we are then going to get compensatory spike in blood sugars because of this. But here's the kicker: in late stages of dumping syndrome, things change. In late stages, the patient ends up with hypoglycemia. And this is because in those early stages, they had a large spike in glucose and then they had a large spike in insulin. Because if I have a large spike in glucose, I'm going to have a large spike in insulin. Once that large spike in insulin occurs, it has this latent effect where it causes their blood sugars to then tank and drop. Some additional labs you might see with late dumping syndrome would be low albumin and low sodium, because again, these are very closely drawn with fluids. So, whenever we have fluid shifts or fluid loss, we're going to have a loss of our albumin and sodium too. They'll also have some tachycardia, sweating, and difficulty concentrating in those late stages. If a patient continually experiences dumping syndrome, they may experience weight loss and malnutrition due to inadequate intake in malabsorption. So, the primary nutrition therapy for dumping syndrome would be to restore that normal nutrition status, reminding the patient of focusing on proteins and fats that will be much better tolerated and digested much slower than that of these very sugary carbohydrates. If the patient can tolerate complex carbohydrates like starches, they're going to do so much better with that. In general, with dumping syndrome, the patient needs to focus on more slow digesting nutrients. Mainly use, it's also been mentioned in the text, fiber supplements, particularly pectins or gums, can be helpful because they form gels with carbohydrates and help delay that GI transit. Now let's dive into our favorite section of the podcast, our practice questions of the day. Number one: a patient is 1 year post bariatric surgery for Roux-en-Y bypass surgery. They report fatigue, pallor, and koilonychia. This is likely due to a deficiency in A, calcium, B, iron, C, vitamin B12, or D, vitamin K. A patient is 1 year post bariatric surgery for Roux-en-Y bypass surgery. They report fatigue, pallor, and koilonychia. This is likely due to a deficiency in. Using process of elimination, I'm going to see what my best answer is. For A, calcium. Okay, so I know calcium is definitely a huge piece when it comes to bariatric surgery. I don't know if these symptoms fit, but I might just place a little question mark by it for right now. B, iron. I think iron is a good fit here because the fatigue, the pallor, and especially the koilonychia, which is that spoon shaped nails, are pretty close to what iron would show for deficiencies. I would place a little check mark by iron. C, vitamin B12. Well, I'm going to eliminate vitamin B12 here because I don't think it fits very well for all of the symptoms, maybe the fatigue and the pallor, but not the koilonychia. So I'm going to get rid of vitamin B12, answer C. And D, vitamin K. I would get rid of vitamin K here because I don't think it fits at all with our deficiency symptoms, and so I don't think it's a good fit. So if I'm stuck between A, calcium, which I was a little questionable on, and B, iron, which I felt very good on, I'm going to go with iron as my best fit for this for number one, and that's going to be our right answer. Number two: which of the following would be the best choice candidate for bariatric surgery? A, BMI of 37 with no comorbidities. B, BMI of 35 with type 2 diabetes. C, BMI of 30 requesting cosmetic weight loss surgery. Or D, BMI of 25 with hyperlipidemia. Let's use process of elimination to choose our best choice candidate for bariatric surgery. For A, BMI of 37 with no comorbidities. Okay, well, that BMI is quite high, certainly, but the fact that they don't have any comorbidities kind of tells me that maybe they're not the best candidate here. I am going to get rid of A, but I could always bring it back if I thought these other answers weren't a good fit. B, BMI of 35 with type 2 diabetes. Okay, so this would be a BMI of 35 or above with comorbidities. This would be a good fit, and I think I'm going to place a little check mark by that. C, BMI of 30 requesting cosmetic weight loss. Hmm, that feels like an off answer to me, folks, and you would probably agree with that. BMI of 30 just for cosmetic would not make them the best candidates compared to these other ones. I'm going to get rid of C. D, BMI of 25 with hyperlipidemia. Well, overweight BMI, hyperlipidemia, comorbidity, I still don't think they're the best fit for someone with bariatric surgery, so I'm going to get rid of D. I would say that my best answer would be answer B, BMI of 35, which is a requirement if you have comorbidities. If it was just the BMI of 37, like in answer A with no comorbidities, that would not be a good fit. Our best criteria is a BMI of 40 with no comorbidities or a BMI of 35 with comorbidities. Answer B will be my best fit for number two. Number three, a gastric sleeve post op patient with type 2 diabetes experiences hypoglycemia approximately 3 hours after consuming a high sugar liquid. The patient is on SGLT2 medications but does not take insulin. The cause of the hypoglycemia is A, lack of insulin secretion secondary to type 2 diabetes, B, SGLT2 medications causing hypoglycemia, C, increased insulin secretion following ingestion of the high sugar liquid, or D, lack of pancreatic secretions. A gastric sleeve post op patient with type 2 diabetes experiences hypoglycemia 3 hours after consuming a high sugar liquid. The patient is on SGLT2 medications but does not take insulin. The cause of the hypoglycemia is okay, process of elimination time, folks. A, lack of insulin secretion secondary to type 2 diabetes. Hmm. I think I would get rid of this one first. While some people with type 2 diabetes may have a lack of insulin secretion, it's typically type 1 that we see a lack of insulin secretion, whereas type 2 is going to be a insulin receptor issue, right? So I don't think this is going to be a good fit, and I'm going to get rid of that one. Yeah, I'm going to get rid of that one. B, SGLT2 medications cause hypoglycemia. Well, I don't know if this is a true statement for these medications. I don't think SGLT2s will cause hypoglycemia necessarily, not in the way that like a GLP-1 or like a sulfonylurea would. Um, I don't think that's the issue here. I think I'm going to get rid of B or I'm going to place a question mark by it, either or. C, increased insulin secretion following ingestion of the high sugar liquid. Okay, so this feels like it fits well to me because I think the patient could be going through some dumping syndrome type of symptoms here. I think C is a good fit because in dumping syndrome, you get that initial hyperglycemia, and then later, once all the insulin kicks in, we end up with hypoglycemia. I'm going to put a check mark by C. D, lack of pancreatic secretions. Well, the patient got a gastric sleeve. They still have pancreatic secretions going on. We don't skip that area at all. So I'm going to get rid of D. For this one, number three, my best answer will be answer C, increased insulin secretion following ingestion of the high sugar liquid. That wraps up today's lesson, students. I hope you watched, listened, learned, and enjoyed today's show. Remember, passing this exam is a journey. We all need assistance along the way. Do yourself and do me a favor. Hit the subscribe button if you haven't. Tell other studying students. Rate, review, comment, help spread the word. Don't forget to join us for YouTube Live on February 4th to review EN and TPN. And as always, remember, happy studying to you, RD to be.